Dr. Helen Mayberg. Dr. Mayberg is a neurologist. At Mount Sinai and the Icahn School of Medicine, she is the professor of Neurotherapeutics, spanning across neurology, neurosurgery, psychiatry, and neuroscience. Dr. Mayberg founded the Nash Family Center for Advanced Circuit Therapeutics at Mount Sinai and serves as its director. As many of you will know, Dr. Mayberg is a game changer for our field. Her vision and discoveries have made precision medicine in psychiatry possible. It is simply astonishing how many pioneering discoveries she has achieved in her career. She developed the first model to explain depression as a disorder of human brain circuits, anchored in neuroanatomy and neuroimaging. It was a truly revolutionary new way to think about depression. Beyond symptom descriptions and neurochemical approaches alone, this model has been the catalyst for our field, and it continues to motivate the work of many hundreds of labs and investigators around the world, and I count myself among those. Based on a circuit model, Dr. Mayberg has pioneered deep brain stimulation as a novel therapeutic for treatment of individuals with depression who are suffering greatly because they do not benefit from other available treatments. She now incorporates computer vision and machine learning methods to continually optimize and personalize her novel approach. You are truly in for a treat today. I'd like to add some personal thoughts, having had the privilege of knowing Dr. Mayberg for 15 years now. She has been an inspiration and a friend. She has forged an extraordinarily important new path for our field. She has been willing to defend each new approach with unwavering patience and solid evidence. She hasn't been swayed by passing versions. I'm grateful for our many discussions about both science and life. She has pushed me to do better in my circuit understanding of depression and always to think beyond the obvious. As you will experience today, Dr. Mayberg is incredibly generous in sharing her knowledge. Not surprisingly, her exceptional work has been recognized by many prestigious honors. Last year, she was elected to the National Academy of Sciences. She's also been elected to the National Academy of Medicine, National Academy of Inventors, and the American Academy of Arts and Sciences. Dr. Mayberg has received the Stephen E. Hyman Award for Distinguished Service to the Field of Neuroethics and the Gold Award from the Society of Biological Psychiatry, among many others. She also holds many leadership roles, including as president-elect for the American College of Neuropsychopharmacology and her service on the governing board of the Institute of Medicine. Today, Dr. Mayberg will present on the evolution of imaging biomarkers to guide depression treatment. I'm aware we're about to start a little early, but I hope that will give you more time, Helen, to tell us about your wonderful work. Please join me in welcoming Dr. Mayberg to the stage.
Thank you. Well, I hope I can live up to such a beautiful tribute from my friend, and it's my honor to be with everybody here and to see what's been accomplished with this center and its vision. And I really salute your holistic approach to things, and kind of want to take this opening talk to really introduce the idea of what is the evolution of thinking about precision treatment in depression, because it's a long haul. And it's, as you might imagine, the only thing I really kind of know about is imaging, and I am a neurologist, so that's always my default position when I say something daft, because I'm sort of a simpleton in how I want to really reduce this story. So I will make it an evolutionary arc, because that was something that Dan had asked me to do, but it is biased by the kind of things we're thinking about more recently, and it really the first opportunity to share a paper that just came out a couple of weeks ago, that 2 years of work. So some past disclosures. DBS does involve some intellectual property that hopefully will eventually do something that gets beyond us doing things in the lab. We are funded by the NIH to do a lot of the recent work, and we've been privileged to be supported by NIH and a number of foundations, which has really been fundamental. I'm going to be talking about unapproved uses of mostly experimental devices, which translates to don't do this in your garage at home. And that's that. I do want to kind of share the fact that this kind of work, you know, we always say this because we have students, we have collaborators, none of this, there has to be a vision of where we're going, but the details is always that matters. And the details have gone from psychiatrists and neurologists thinking about a problem to actually a very computer engineering approach to the problem. But it is always a bi-directional conversation. And I think that's going to be a theme over and over today. And I think that's what's true to do any of this work. But I'll highlight certain people along the way, but there's a clinical, an engineering, and a lot of trainees that are learning how to think in this space, which is a hybrid. It is not one department, it is an amalgam. And I think that theme will come through as well. But again, I want to start by contextualizing this story because, as I had people say to me 40 years ago, as a neurologist, you really can't study behavior. I mean, how do you get your head wrapped around that as a neurologist? And when you really look at how patients describe the experience, the clues, I think, are all there for how to think about the brain. The two pictures are drawn by two of the DBS patients. And what's really fascinating about the two of them, the one on the right is actually a professional graphic artist. The other is a guy that just really wanted to try to explain the metaphor that he experienced of drowning and bobbing versus drowning. Patient on the right actually captured what it is to be in the state that William James described about his own depression, about an active anguish. And I think this theme of mental pain, inability to move, self-loathing, this idea that in your most extreme state, you can't move away from it, to me is actually the fundamental of what the illness is that I think we're treating. And the rest is explanation. And again, that's an antithesis argument to Dr. Williams' approach coming as a psychologist and thinking about the content of thought and measurements of thought. Again, as a neurologist, I kind of like what I can examine and what I can observe. And I think, again, when we think about developing biomarkers, we have an exam, and most of the things, even in a psychiatric exam, are not observed. We ask questions, and they're not really measurable, that we need self-report, and that is a quasi-measure, but not a very good one, as we all know. I think if you watch depressed people, the movement part is unavoidable. And as a neurologist, where you see a lot of Parkinson's patients, the interaction, the posture of actually differentiating a depressed person from a Parkinson's person when they're standing or when you're looking at them, you can tell the difference, but there's something they share that is obvious, that is a clue to what is going on in the brain. And as Duchenne described, he went around poking people with electrodes and trying to evoke facial expressions and mapped out all the action units. That is what Icahn spent the whole rest of his career doing without a cattle prod to people's faces. But that's where Darwin got his first introduction about the nature of facial expressions. And again, we know the neuroanatomy of facial expression and how the face moves, and we kind of ignore it. But these things are really just staring right at us. And we use them all the time in our own deep learning models as clinicians as we interact with people. You don't need a Hamilton depression score to know when the patient you treat is actually starting to do well. You watch them bounce in, you watch them sit down, you look at the look on their face, and you know, you do the little happy dance in your head that they're better. And then you ask the questions. So I think this really comes down to, once you actually realize there might be something to measure, is how do you quantify it? And again, neurologists by definition are lumpers, not splitters. We look for patterns. We don't look for everybody's special. Of course, everybody's special. So again, you know, two of my teachers, both a neurological perspective, but then Paul McHugh with the perspectives and the idea that you have layers in psychiatry of how to think holistically. At some point, the question is, what can you reduce this set of expressions that people complain about? And it really comes down to feelings, thoughts, and actions. And the question that we grapple with is, in what order do things spin in these interactions? And well, they're all happening at all the same time. The brain isn't working as A to B to C exactly. Information does flow, but it really is the net sum. And I think that's what we're trying to deconstruct. But I found this quote, and I woke up this morning trying to remember where I saw it because it was pretty recent. But I think it's really stunning, because I used to make the joke that, you know, what would Freud do if he'd had a scanner? Well, based on what Freud talked about, he actually didn't believe that any of these mental processes lived in the brain. And maybe if he'd had a scanner, he would have changed his attitude. But I think it's really stunning to actually kind of see that his belief that the psychical topography didn't have anything to do with anatomy, which is kind of a funny thought in retrospect, but how could he know? And it's situated somewhere in the body, which I think is interesting, that just like Hippocrates, there is a sense that the body and the brain are connected, and the question is how, and now we're getting a clue on that. But I think, you know, at any point in the trajectory of scientific discourse, whether it's 40 years or 10 years or the cycle of a grant, which we all live and die from, there is a long history about trying to get at what these feelings are and how people suffer. And now we have tools to do it. And, you know, the evolution of this, and seeing Dr. Fisher in the audience, we go back a long way, back to these times, and he's here with all of you in the epilepsy neurology department. This all goes back to a paper that I read when I was a resident, 1983, and it was Bob Robinson's paper in Brain on post-stroke depression, which was revelatory for me, because as you would see, neurological patients, some had depression, some didn't. The basal ganglia patients had depression, the epilepsy patients. And in neurology, we were kind of ignoring it. And Bob and Tom Price at University of Maryland was trying to study it systematically. Not that wouldn't she be depressed if you had a stroke, but what is the systematic location that produces a stroke, and to see it like a result of the lesion itself, except unlike getting hemiparesis, it doesn't happen immediately. It evolves over about a month. So it's a maladaptation to a lesion, and it goes with more in the left frontal pole than any other place. But what gets missed from that paper, and I should have put it on here, is there are two other places that are equally possible. 60% are in the right frontal pole, but split between biparietal cortex, right and left. It's the other place that gives you a lesion. If you actually lay that out, and I should probably add this to this slide, it's a default mode dominated by the left. It's not lateral frontal cortex, it's frontal pole. It's biparietal. Why should it be biparietal, not just left? The other observation that Bob made with the guy on the right, Sergio Starkstein, neurologist and psychiatrist from Argentina, now in Australia, was they all started working together with Maitland DeLong. So all these people were coalesced at Hopkins, where I joined the PET scanning team, which is where I went. Bob, where we were studying opiate receptors in epilepsy patients, sort of far afield. But we all got together and we started using Alexander, DeLong, and Strick's model of basal ganglia circuits to test a circuit that had never been tested. How does basal ganglia disorders, Parkinson's, Huntington's, stroke, how can we actually look at maps? Because if depression in neurological disease doesn't have a map, we have no business looking at maps in primary psychiatric diagnosis. So it was a fast to fail set of experiments. And with Sergio's examining every patient there was in Bob's lab and working with Malin. This was the beginning of a collaboration across the centers. And we started to notice that there was a common pattern in depressed people independent of etiology. We could then extend to look at people with primary depression who are inpatients, and we could start to build these putative models. There's no theory involved here. This was just collation, accounting. How can a neurologist take blobs in the brain that seem to be connected to each other and actually wire them up so that you're actually seeing if they fit anything we know about brain areas talk to each other? And all of that work was done inferentially by reading maps of non-human primate anatomy. These were metabolic hotspots, cold spots. But over time, these models evolved. They were all data-driven. They were experimentally driven. If you got a finding, don't put them in alphabetical order in a table. Actually organize them by what systems of the brain do they belong to. And through that process, a map emerges more by convenience than, and supported by the literature, but not by any super data-driven, graph theory. None of that was really done yet. And then you had people like Suzanne Haber, who were actually defying the idea that these basal ganglia circuits were segregated. There were big fights then, but she was data-driven with her anatomical maps and the complexity about different parts of the cortex, talk to the basal ganglion where, actually helped us to refine how we were thinking about what brain area is doing what, how to do purely correlational analyses. And we started to build up these iterative models. Again, more to highlight where we had findings from an experiment, which were groups of patients comparing, people on a drug, people on different drugs, getting better, not getting better. It was really very linear in its thinking and just really organizing the information in a way so we could communicate with each other and with other people. And I want to kind of stop at this point to kind of go, that was our process, my process. And that, like I said, it was always about an experiment. Where are findings? Where are findings the same? What do we know by anatomy that we can read? And there are many other approaches. And I love Leanne's circuit taxonomy approach that really is theory and data driven. And it's such an organizing principle contemporarily. I love the idea that you can just take data and throw it into a big machine and out pops an answer, and then you can have explainability or not. I'm actually starting to be a believer, and you don't always need explainability if it works, but kind of like explainability, so that's okay. You can have canonical hierarchy models like Connor Liston's team has invoked. You can start to do resting state parcellations and give names that then could be tested in models like Leanne's. All of these are good. And the approach that we did is, again, very, very simple-minded. They have a map of people who are depressed, and the frontal lobe was always low, that we had people that were treated, and we started to see, if you looked at baseline, what was different about the people who did better and the people who didn't. This was the first time where suddenly there were things that were common, but there were things that were different. And the things that were different seemed to be pretty simple. And the things that were different got us thinking about what's the role of the cingulate, and why should the rostral cingulate be in an upstate in one group and a downstate in the other when everything else is the same? I mean, it's descriptive more than anything else. But then what we did is we took that further and said, as we were studying that people got better on therapy versus drug, let's take the same approach. How can we randomize patients and kind of say, going to scan you at baseline, we're going to put you into expert psychopharm therapy for 3 months or expert CBT for 3 months, take care of the patients as a team. And at 3 months, you're either well or you're shouldn't have bothered, less than 30%. And can we build a model that says, is there a difference that could have predicted which group you're in? We even forced the model to kind of say, we want a region or a finding that actually works for both treatments. You win with therapy, but you fail drug. versus you win with drug and you fail therapy. And there were 6 candidate regions that fulfilled part of that criteria, but the right anterior insula fulfilled both. If you're metabolically high, you do great on drug, terrible on therapy. If you are metabolically low, you do great on therapy and terrible on drug. And we even tested that prospectively, and it seems to fit, but not robustly, and certainly not enough to do a PET scan on everybody to decide how to treat. But when you look at the distribution of the patients, you realize you actually could. And what you could also do is if you treat people by the second treatment that they weren't randomized to, you can test it to see if actually I give you the treatment that matched your brain, do you get better? And you do. Except then there's the people that fail both treatments. And this is how you start to kind of say, what's special when I meet you that you might actually not need either one of these first-line treatments. And this is like, you'd think I'd painted this in because this is kind of a more contemporary picture after we'd started our DBS work. But actually Area 25 was overactive in these group of, for the most part, responsive patients and the people who just failed to first-line treatments. So again, we start to get a clue of how the brain is not in the same state all the time. It's changing. People can look the same. Their symptom profiles may be similar or different, but there's something fundamental about what the brain is doing that's implying it's trying to adapt, but it's not doing a good job, because if you adapted well, you wouldn't be sick. And we moved to fMRI, and I think many of you are familiar with this work in the PREDICT study. It was around the time of iSpot and Embark. Charlie Nemiroff and then Bodie Dunlop and Craighead and I, we had a big project, never treated people. We did resting state fMRI, same design, drug and therapy. In fact, the PET scan project, fMRI project were happening in parallel. So same logic. If I look at failure and win at the end of 3 months, we also got a pattern, except what we did is we seeded it with Area 25, and we got a network, 3 regions, all connected to Area 25 functionally. Turns out they also connect Area 25 structurally. If you have a positive connectivity to these 3 regions, you do great on therapy, but terrible on drug, and vice versa. So this logic that whether you see a region, you see how other regions respond to it, or you kind of look at the whole brain, but the idea that people can be in different brain states and actually determines where they go. And then we actually added a layer to say, well, if you're well at 3 months, we actually knew that there was a subset of people, first treatment, totally well, in remission, that actually relapsed within the next 2 years. How do we know? Because we followed them. That was part of the continuation of this grant. Small subset, people had never been treated before. We looked at 3 months and said, what about you might predict that you're actually not going to do so well? Not when we first met you, but 3 months when you are well from that second scan. It turns out Area 25's connectivity to the right insula now, kind of in the same vicinity of we'd seen the original PET-SAN finding. If you had increased connectivity of Area 25 to that region, you had a recurrence within 2 years. And that if you didn't relapse, you never had any change on treatment. So this is a change pattern. Everybody looked the same at baseline to predict remission, but the ones on treatment actually had a maladaptation that was going to put them in trouble. And I'd like to kind of prime that this is something we might think about. What do we do? What is the price of getting well on a treatment that changes your brain? It will have good effects, potentially bad effects. And what does that mean as we start to think about neuromodulation or things where, you know, there is no negative pharmacology? And what we then could do between these various experiments is say, well, what do all the non-responders, dual failures have in common? We started to see what they have in common is the connectivity of Area 25 to a region that comes up over and over and over again in change patterns. It is in the mid-cingulate. It's the motor, it's near the supplementary motor area. It's part of the cognitive control network. It's part of every resting state study that looks at hubs. If you do graph theory, that this is a very, very interesting area that projects to the body. And so this disconnectivity was something that we were seeing in these various groups of patients and people that do badly. So as we're starting to I'd always had this delusion, it was more a fantasy, but I realized it was a delusion, that wouldn't it be great if at the beginning when we meet people that we know that they're in trouble, so we don't waste 10 years of treating them with things that don't work and they lose valuable time in their life and relationships with their families. If we just knew you were going to be one of those, we'd save time. And what we've learned is it doesn't really work that way, that even every DBS patient, for the most part, their story is they had a regular depression, they got treated or didn't, and they got better. And then over time, stuff happened. They stopped responding. Good doctor changes the drug, adds therapy, reduces their stress, changes their diet, whatever it is. But what is it about this graph on the left that says by the time you've had 5 episodes, what's the likelihood if I can get you well, I keep you well and you're well a year? Dismally decreasing over time. Read STAR-D, this I think came from STAR-D. Sometimes you have these pictures that work for you and then you don't really maybe attribute them for the way they were intended, but I'll just take that poetic license for this talk. But in fact, the idea is what is really being said, because what do we do for people that fail 4 treatments, 2 we all argue about what's treatment resistance. Well, whatever we decide for whatever trial, but 10% of people have malignant transformation, they stop responding. What does that mean? When we started thinking about this, it's exactly 20 years ago. First implant that I did was May 2003. There was no VNS approved. There was no ketamine approved. There certainly, what has happened in 20 years? Lots of good stuff. But what does everybody struggle with? Durability. We reframe each of these treatments coming back. It's about durability. What do patients want? Need to have confidence. Well, what patients want is, get me out of this burning pot of oil. Whatever you can do right now, that's what I want. What they really want is, I want to get well and stay well. And what is that state to be able to move in and out of a state and not stay out of it? It's an attractor state. And the question is how do we have an evolution, and how maybe not the symptoms at that point, but what is the state? And that's where the brain can be very helpful. And again, because I want to share the new stuff and not the old stuff. Area 25 was the origin story of everything. When we treated that first group of people that we saw had the rostral cingulate up or down and predicting how you did, what was also in that first experiment, which also included placebo, so that one group of 17 people had 3 of our most seminal findings to be able to know what predicted outcome, what went with you could get better with, whether it was active or inactive, and what was the change pattern that went with being a responder. And the change pattern was downregulation of 25. We were hunting for just correction of frontal cortex. That was the logic at that time. When we saw the data, I thought we'd misaligned the data, because there was this change pattern that had decrease in insula and decrease in 25. That was the origin of all of this, that what was area 25, and it wasn't abnormal to start, it downregulated. Placebo response downregulates area 25. And if it doesn't decrease, you don't get better. You start looking at the literature, it's in OCD, in VNS, in TMS. All the early studies all had it. None of us knew that it was a common theme, because you're describing everything in the brain that changed as opposed to what thing might be in common. So this experiment was literally, if you can't drug shock or, talk it down, then around this time, DBS for Parkinson's was in full swing, that you could implant an electrode, and the logic of what DBS for Parkinson's did was depolarization block. I had no idea what that really meant physiologically, but I heard block and downregulation. It's like, okay, that's what we want. So if we can put this electrode in and stimulate at high frequency like Parkinson's, we can block the activity in area 25, And everything that's connected to it, even if we can't see it, should be disinhibited. So if area 25 is in a reciprocal relationship with prefrontal cortex, which is the origin story of TMS, that's what we got with mood induction. That's what we got with fluoxetine in those first days. You couldn't separate 25 going down and frontal lobe going up. So let's go at 25 and see what happens when we stimulate it directly. And so we guesstimated from the PET scan, not very precise in our precision story, but you can implant and stimulate and see what happens. And what happened was very rapid effects. Again, at that time where people didn't really have this experience with accelerated TMS or ketamine or psychedelics, to be in an operating room with an awake person with absolute clarity, put it in, turn it on, pray that nothing bad would happen, because those first experiments were not blinded, because they were safety experiments, and to see that in some places and not others, people switched out of the state and they went from one state to another. And with a little bit of stim every day in the hospital while we were just watching, you can see the graph that there was a decrease over the course of an hour of messing around in the hospital, coming in and turning it on and see how they were. At the end of 5 days, these people were well. Sounds a lot like accelerated TMS, but didn't keep getting in the chair all day. And when you turned it off for a week, you got a little bit of a loss of the effect, but you can see they didn't go back to where they started. Again, we missed that also, then turned them on, left it on. And in about 2 months, you could tell the people who stayed well from the people who lost it. And we would try to recapture it by changing where we would stimulate. And when we looked at the PET scans, we got exactly what we wanted. Downregulated area 25, increased this reciprocal change in prefrontal cortex. So the hypothesis appeared correct. And that if you kept people on and continued to stimulate kind of indefinitely, kind of set it and forget it, you can see the graph that Kennedy, we published on the first 20 in Toronto, 6 years, that basically if you got better, you stayed better. So that was pretty cool. And in the meantime, other people had other logic. Maybe we should go in the monoamine system. Let's go in the medial forebrain bundle. Let's work and build off of the experience of lesions or in what was going on in OCD, because when you're in the anterior limb of the internal capsule, you get a big positive mood effect. And so there was a line of reasoning there. And this is when everybody kind of got excited. The problem was when you set up the randomized controlled trials, they didn't work. It's not that people didn't get better, but the design of the trial didn't work, which got translated to none of it works in people who have failed everything. So suddenly you have this disconnect between what is happening in the wild and what's happening in a trial. And it wasn't that maybe people need to be matched for the right treatment, which was one logic. But when you basically have an implant, you don't stop trying. You just don't take the implant out or discontinue the treatment. This is one of the advantages of an implant, because people have an implant. So you can continue to look at it. And even if you don't do anything, that you actually, as time goes on, that you actually see that maybe it's the timing of your trial that was off, or that some people take more time to get better. And so how do you leverage that information? So again, this was a pretty dark period for me, because in our own hands, we were doing well, but we were doing experiments and not randomized trials. We did a 1-month single blind in our first study at Emory, and basically implanting and not turning it on, you don't get a placebo effect, but it was a small number of people. But those failed trials basically were like the dark ages, because that meant it doesn't work. And that means, why are you trying? Made it hard to publish. It was impossible to get a grant, even having people doing well and having the data speak. So again, battle scars are not attractive to share in public. But again, the patients are better. So whose fault is it? And everybody's pointing at everybody else. And everybody, the psychiatrist, you can't even prove that you're wrong, because how do you pick the right patient? So everybody was like, Helen, have special powers to pick patients and everybody gets better for me. I wish anybody listened to me like that. But The idea is that how can we find the part that we can control, and where can we have precision and reverse engineer what we're doing wrong? And there's only one place, because you can't change the whole system. And the one place is where. It's not like you can ever tell a surgeon what to do, but you can actually show them what they need to do. And that's what they want to do. And what we came to realize, which we always knew, was that even though you're giving a cloud of current, is that exactly where you put that current is essential. And it's essential at the level of millimeters, which seems crazy when you think about, doing TMS and getting in kind of the vicinity. When you're deep in the brain and you've got an electrode that's got a spread of 1 centimeter and a contact is 1.5 millimeters, basically you can have the approximation, but it turns out when you could map the white matter, you're at the intersection of 4 bundles. And when you start to really realize and reverse engineer, what am I hitting and what am I not? And again, it came from examples of what you think is a perfect patient who didn't get better, and you realize you're probably missing this kind of putative spot, and you convince the surgeon to go in and change it, even though he thinks you're nuts to move it 1.5 millimeters, but then someone goes from not being better to being better. Then you can reverse engineer and say, what did I do consistently in people who got better versus not? The same logic in all of the other studies of what's a responder and what is not. And you start to see that the where can be predicted. And instead of just doing it after the fact and comparing it, it was actually figuring out what was in common in every responder and building the template, the blueprint to say, this is where you put it, the intersection of these 4 bundles. And now let's test that prospectively. And that's been going from, you can see the curves, a 40% response rate, then, moving around, you finally get the right spot because you're approximately right, to putting it in, turning it on, and never changing where you are. First group was 73%. Again, groups of 10, small numbers. Now we're up to 9 out of 10 in the last 2 cohorts, even changed surgeons, changed psychiatrists. One variable, one approach, one map made all the difference. And that now, the Emory cohort is, many, many years, and that you get better, you stay better. That doesn't mean you don't have ups and downs. You never go back to that place you started with, which was being ECT failure, 4-drug failure. And everybody now has had ECT, ketamine, TMS. People get better like the attractor. You move out a little bit, but you fall back in. Now you're out and you pretty much stay out of that part of the pit. And we were able to go back to the data from the Broaden study, the failed study, no tractography, but to use these tools that people have developed. This was Andy Horn's lead DVS. We had the location of where people were at 2 years. 50% in the Broaden study were actually well at 18 months. 17%, 20% on average active sham at 6 months. That's why that trial failed. But at 18 months, open label, 50% persisted at 2 years. We took what they were being stimulated at 2 years, looked at the people that didn't ever respond over the course of 2 years versus people that were better at 2 years. And we could tell that actually what had happened is the surgeon had missed the left cingulate. So again, you don't put it in the right place. You can say all you want about bad patients, bad design, bad whatever. You better get it in the right place or there's nothing to discuss. And that allows you to actually revisit a trial that was a fail and actually kind of start to think about doing it again. But once you actually trust where you are, scientifically, the notion of understanding mechanism, precision, all these other things becomes easier, even in small samples. And what Alison Waters did, and Ki-Sung Choi is really the mastermind behind developing all of these tractography methods. I went through 5 graduate students with people trying to do a way to get these white matter maps. They all went into other things and did other things, but Ki-Sung was a biomedical engineer who again joined the lab, was at Georgia Tech and had access to these data, and we figured it out with Paul Holzheimer. And he now works with Alison Waters, who's an electrophysiologist, and looking at high density EEG. What happens when you're in the right place and you ping the brain and you get a stim evoke potential of what you're doing, even at low frequency. How does this move through the brain? This is what Corey Keller does. This is what many people here are doing. This is looking at this one spot that works, and there's a topography. The stim evoke potential is 4 components. It's the same in everybody. It's the same over time. It gets stronger as people get better, but it's the same map. And even in a given person, if you compare the place that got them well with versus the adjacent contact, millimeter and a half away, and you ping it, you can actually see sometimes it's similar, sometimes it's different, and you can get a map on the cortical surface. There even looks like there's a dose effect. You can start to see how precision of when you're in the right spot, verifying what the spot is, can actually do more. So that puts you now in the position is, well, where is the variance? Why is it that some people are better at 6 months and some people are better at 2 years? Because that also includes not everybody got better even when they're in the right spot. And this is what Patricio and Andrew Crowell and now Martin Fagui at Sinai, what everybody who works with these patients sees. People get better fast, then they kind of coast, then they get a period of instability. Andrea Crowell, who also both did electrophysiology at Stanford when she was a medical student, and worked with Phil Starr at UCSF, but also trained in the Psychoanalytic Institute. So that's a confused psychiatrist. But what did she notice as she would take care of the patients? At 4 months, she goes, it's like they're regressing. They're becoming teenagers. They're obstinate. And we would call it the rough patch. And you can see the rough patch kind of emerges in these people. You start to rationalize, people are getting better. They're emerging from this depressive cave. Their families expect them to do things like, what's a rough patch mean? As you venture out, you're getting prediction errors. You can model it in all kinds of ways. But when you look at the individual variability on the Hamilton, the yellow line is when the psychiatrist decided to turn the current up. That's the only thing we let them do. Increase current, no other parameters. You see that they're not even consistent with what they do. It's madhouse. You have to decide, you use a Hamilton, but then you're talking to the patients and you're kind of listening to what they say. You go, you're having a bad day, you're having a bad week, you have a life stressor, I don't think your depression is getting worse. And you can see their behavior, you can see the need, like, what's the rule? And you can see how disastrous that is in a clinical trial to make a rule. So we kind of said, okay, we need a way to have a readout on what's happening over time. And this is where technology came in again. And so we knew that there were these very, very fast effects. We modeled them. These were some of the most fun papers. I kind of felt like Penfield, because we'd be in the operating room, we'd try stimulating different things. People would say stuff, we'd collate the kind of things they would say. And as you kind of even read this person describing this emergence from this attractor state, there are all these metaphors of verticality. And these are the kind of things people said on the table with, as you gave stimulation, a minute into stimulation, you got this. And that's all fine. And that's good for, it's really interesting, but it's not a readout. But in fact, because people are wired in the operating room and you have the electrodes in to do that clinical experiment, you can run the electrophysiology rig in real time, and you can look before and after these stim effects, that once we knew we were in the right place at the end of checking for safety, we actually turned it on and left it on for 5 minutes, bilateral stim, and watched these people emerge. And we got the electrophysiology off of local field potential, off of area 25 in the blue bar before we started stim, and at the end of 10 minutes of bilateral stim. And we literally had a computer science student. We didn't need computer science, just need to look at power spectral density, which Allison did. But we built a model of, can you tell the difference between the beginning and the end? Sick, different, everybody's the same. There's a pattern over area 25 that distinguishes the two states. Everybody's got the same pattern. That's an average of 9 people. Everybody had an effect on behavior. Our mistake was we didn't have a good quantifier in the OR, but we knew how they were doing a week later with no more stim. And you can see the Hamilton, a week after post-op, there was a dramatic change, and that the magnitude of the beta decrease that we produced in that 5 minutes of stim correlated with how they were doing a week later. Oh, thank you. I sound a little ratty, sorry. The problem is couldn't get this paper published despite the fact that everybody had the same signal, and these were people that all get well, because it wasn't predicting 6-month outcome. So what's the point? A clue that we didn't heed immediately, because the question is why didn't it predict long-term outcome? But we had a new trick up our sleeve because the device actually now had a recorder. So we'd done all these experiments in the operating room. That was the only place we could do the experiments. We had to do high density EEG or PET scans after. Now actually the device itself can record and get, if in essence, telemetry off of area 25 all the time. Not all the time exactly. Could take samples, 9 times a day. You had to download it, could only hold 15 minutes of data. We gave it away to collect data. The signal was terrible. We could bring them into the lab once a week, download the data from the home, and then do a recording that was clean in the lab. And so every week for 6 months, we got a recording of area 25, how they were doing. And what Shankar Alagappan, who's a neuroscientist and engineer, Chris Rosell, a biomedical engineer, IEEE kind of person, they decided to take a signal processing approach to this signal, because when you just tried to correlate what was happening with the Hamilton, that wasn't working either. So there was something very important about what was happening just as a function of the score wasn't it, and everybody was rationalizing why. But look at the behavior that we have. We could build a training set. So we had 9 out of 10 people get better. We took a training set of 5 people with very good data, and everybody got better. And we took what was happening at the end of 6 months, that last month, compared to the first month, and we built the same kind of classifier as we did in the OR, beginning and end. There's no ambiguity. I don't need the score. You're well. These people were well. Look at the line of that's a response. These people were mostly in remission. We built a classifier and said, can you tell the difference between first month on stim, different but not well in the last month of stim? And the answer was, yes, you can. And it's not special for every person. It's the same model for every person. And that's the classifier performance for people who like that kind of stuff. It's I think 87%. And then we said, okay, what is it? We're going to take that signal. We're going to go every week and say, when do you convert from being sick to well? What week does it happen? And you give it a rule and say, well, a rule for stable well. 2 weeks in a row, the signal has to be in the well state 2 weeks in a row. If it's going to vary, it can only vary for a week. And if it varies for 2 weeks, doesn't matter how much, you're not well, not stable. Give it the rule, find the week. Everybody's week for stability is different. Then look at how well did it do to predict the same rule clinically. Not as what does somebody think, what does the rule say? Hamilton, 50% drop, 2 weeks in a row, can't vary, not even to 49% for more than a week. You drop below the threshold and you stay there. And actually, that's the classifier performance of that the brain state can predict the clinical state of wellness. And then you can understand which of the features in this complicated electrophysiology signal is driving it. And it turns out it's beta and gamma on both sides. There's more, for all the physiologists, it's more left beta and right gamma. But even as we replicate, I'm not sure you can reduce it to practice to one thing. And so now this was the first data set. This is the paper that just came out. And we have a new data set with a new device that's fancier, but not fancier. It's also a prototype, doesn't exist, but we're this general signal, just applying the same signal and looking at this, it works. So we now have a marker of the finish line, not how you get there yet, but where you need to be. And, the question everybody asks, well, is there anything else you can use to build to know how someone's doing? And the answer is, yes, you can. That we actually had video recordings every time they came to the clinic. And now we do video recordings at home twice a day. so that people are talking to themselves and making a record that I'll talk about in a second. But what Steve Heisig built was basically a model of face movement the same way, had video once a week, built the model of what's happening at the end versus the beginning, could build a highly verified, very reliable classifier. The face change goes with the brain change. And what features does it look like? Exactly what Darwin and Duchenne and Ekman said it would. And which is nice because the cingulate is the emotional face. When you damage your cingulate, you have slow volitional movement, you have no spontaneous movement. It's bilaterally symmetric. It's a very different system than you get a middle cerebral artery stroke and your contralateral face doesn't work, but your emotional face works. Right in front of us. What's the wiring diagram of facial expression? It's the same one that we're stimulating. So what can we do back to imaging? Here you can see on the left that different people, this brain biomarker and their clinical marker is changing at different rates. So we went to look at, well, what's wrong at baseline? We have no ability to put these people back in the scanner at this point, but what did we know at baseline? Back to our strategy of what at the beginning could we have known to predict something about later? Well, it turns out that if you look at the pathways that we were stimulating and looking at the integrity of the white matter as a function of how long it took to get well, actually turns out their hits in the white matter are proportional to how long it takes to get well, which in other words is, the more damage your brain, the longer it takes for the stim to fix you. Again, now that sets up the experiment to know what is repair, but that we also looked at the functional connectivity, and what came out of the functional connectivity is back to our friend, the mid-cingulate, and that area correlated with the white matter abnormality. It correlated with the number of episodes, which went back to this issue of what contributes to the last straw of not being able to stay well. And we're back to this very funny hub region where all of these networks converge. That laid the groundwork for actually saying, well, we don't know if it repairs. And now we're looking at how does white matter change, because we can put people back in the scanner and we know where to look. But we started to do this in monkeys with collaborators at Sinai, Peter Rudebeck and Brian Russ, and their postdoc, Satoka Fujimoto, actually inspired by an experiment that Michelle Manji did in 2012 in brain tumors and looking at STIM as a vehicle to turn on oligodendroglia. So again, I got to visit with her yesterday. If you don't know her, you should all meet her because she has the answer to our problem, even though she studies pediatric brain tumors. But the notion of what does STIM do, what is plasticity about, what does it mean? What's the role of the oligodendrocyte? How does activity change that system? You stimulate in a normal monkey exactly like we do in the people for 2 months. You grow new myelin. Not only do you see it on an FA scan, and where do we see it? We see it in the mid-cingulate. I did not paint this in. And that actually postmortem, you actually see that you have mature oligos in that site. So it isn't just myelinating the whole bundle. Different bundles behave differently. And this is her work back from 2014. I misread it, but you stimulate, even in rodents, you grow new myelin. It migrates around the corpus callosum, and actually you improve behavior. So we can start to take maps and take this information. What happens with the PET scan? Default mode gets better over time. What happens with early EEG? What's happening early is not what's happening late. What we saw when we were just at area 25, we can start to deconstruct these signals with all of our tools because now we have some logic of where to work. And we can start to utilize what does it mean then to help the physician to make a decision about what to do. And this is the current dilemma. When do I turn it up? And when the patient's having a bad day, is it that they're regressing and they need more current, or are they having a bad day and they need more therapy? And obviously now with this tool, The one holdout in our paper was a woman who got better very rapidly in the operating room, and she was well. She didn't regress over the month off, but at about 4 months, she relapsed, and then we turned her up and we got the recovery. But we went to look at what happened to her brain because we didn't build a model with her for our signal. And it turned out that she was in remission. She had the stable well signal. But what you'll see in the red line is the brain detected that something was going on at 10 weeks. And she didn't know it, and the doctor didn't know it for another 6 weeks. And again, in a conversation with Nolan Williams yesterday, even with accelerated TMS, what is the regression? What's the off curve? You get people well and there's a decay function. It's different in different people. You get to where you know their decay function. It's really interesting that you can identify it in advance. So we've gotten to where, how can we use, like Nolan's doing, like many people are doing, like Leia's doing, if you don't have a recording device all the time to tell you what's happening in the brain, what can you use that you can track people over time? And I think we're all in this space, how to use how people look, what people say, how they move. And our current workflow is people record daily diaries, they wear a watch. We can start to compare weekly measures with daily measures, with twice-a-day measures. We can start to do machine learning of what people say with these big models every week. If you follow, all the information in the history of the world that anybody says or does is now in a chatbot. I mean, everybody's got this data, but we can all get access to it. We can build models of our own data. And what we decided to do ourselves was to take the inspiration of animal researchers of what is naturalistic movement? What is the idea that people kind of go, it's having trouble getting out of bed? What does virtual paralysis mean? What does fatigue mean? And we basically built with Morel Phillips, who comes, she actually used to work on Grand Theft Auto, to actually, I just need another minute, I see the clock. She built us a room built on the Unreal Engine and kind of built an environment that doesn't use VR or AR. It's just a person. Steve, our data scientist, is sitting. He's just, the camera locks into your own movements of your hands, and then you can interact freely. And then in real time, you're getting feedback through the computer of what your movement is, and so you can see your movement. And then you can quantify the movement you have with a simple model like a Kinect camera where you just have joints, or you can actually get to where now you can do it like they do with animals, where you can use the whole video. And again, part of the inspiration was kind of Dr. Strange. I didn't know who Dr. Strange was, but I got an education and realized that what we were doing was kind of what he was doing, except we don't get to transport anywhere, unfortunately. But we can actually co-localize people's recording from their brain, can add EEG, can have naturalistic movement in this environment. And even something simple like you see on the right of just the movement of a simple circle. A person with TRD doesn't move a lot. A person with Parkinson's, it's asymmetric. You can pick up the movement in a way that isn't just you examining somebody. And actually, we start to see that when the brain started to change in patients, their movement changed first before they knew what it was. So I think we're back to what I said at the beginning, how people look, how people act, the idea of not being able to move away from mental pain. That's the problem. Whenever we're in a bad situation, we just move away. What happens when you can't move away, when it feels bad and you can't kind of figure out how to correct your error? And then on top of it, you actually feel like physically you can't move. So I'm just going to end kind of back to what I think the whole purpose of this fantastic center. I think the mission that we all share, how do we use advances in technology, advances in neuroscience to actually take care of people? And what part does the machine do? And what part, if you have a machine, and what part do we use the machine to facilitate change in the patient? We want people to be better and stay better. We want ways to make rules about how we introduce rehab. Rehab has to be at the right time, and you can't run a marathon when your bone is still healing. So when is the right time? Maybe we fight with ourselves. Maybe we shouldn't have people on meds. Maybe the meds themselves compete with the device. Maybe they bias the brain, and maybe we should get people off of meds and see how much you do with the machine and then add meds. That's my vote, and can talk about it later. We have examples. You really need to train patients to know distress from depressed. I don't think you can actually train it. You need an alarm system. And I'm just going to end with patient 815's. You can see the evolution, not just of the science, but of a patient. On the left was how she imagined herself before DBS. And then at the end of 6 months beyond, how basically the future is whatever it's going to be. That I think it's really quite profound. Patience is not her writing, but the idea is, what is predictability? How can I live my life if I'm always looking over my shoulder of when I'm going to relapse? I mean, people who want to interact in the world, you don't want to let other people down. It's not just about you. You know, other people count on you, your family, your employer. You don't take chances. You don't forage because you're worried about what will happen. And how do we, patients recognize that there's security in the implant, because once they trust it and use it, it helps them. And you can see her last drawing that, you know, there's really this, how do you emerge out of a hole? And then I love the green glass. And I think patients need to get well beyond the early parts of a trial to actually realize that I'm learning the difference between depressed and life. And I think that's what we have to capitalize as we develop these tools as we go forward. So I will stop there and entertain some questions.
Thank you for such a brilliant plenary. It was a real tour de force. Everyone would appreciate how you've connected the very sophisticated treatments to the patient. Congratulations on your Nature paper, so well deserved. So we'll have a few minutes for questions now ahead of the break. So who wants to kick off? Is the mic coming to you?
Thank you. Hi, good morning, Dr. Mayberg. Reed Kaplan here. I used to do implantation studies on pre-op patients with temporal lobe epilepsy. So I know how incredibly labor-intensive and expensive it is, especially in 2023. Do you see any future in other technologies, such as high-intensity focused ultrasound or CyberKnife, or perhaps multiple more superficial implantations at connectomes, so you can get a sort of multivectorial focus on area 25?
Thank you for the question. And I think, you know, this scalability issue, and given healthcare and how to actually, you know, hopefully over the course of the day, I mean, because I didn't answer the question, how do you pick the right patient? And I think that's still an open question. But technologically, I think that now seeing the behavior and having a readout over time this way, then we can start to scale back into things that may be accessible another way. And we were, you know, Dr. Phillips and I were talking, you know, this morning about the idea of the order of our technologies, so that we're matching, not just matching people to what they need, but we're potentially preventing progression over time as we use these tools. I think that I've seen data now, you know, from Utah, where targeting area 25 in that vicinity with focused ultrasound, you can get acute changes. It's very reminiscent of the idea of what happens with ketamine, what happens if someone has a very rapid effect with accelerated ultrasound, what might even be what you see with psychedelics, although that's kind of an all-day thing. I mean, I think the ketamine effect, you know, I don't know if you saw it, there was a paper that just came out about people undergoing a surgical procedure and that agreed who had depression, actually when they were anesthetized, got therapeutic ketamine. And actually it's something for us to discuss. Was that study done here?
Yes.
Oh, cool. I just saw that yesterday. I want to hear more about it. But I think, you know, this idea of where does the science converge on areas of the brain, And how does focused ultrasound even potentially be a stress test to know if the brain might respond? I think the work with the focused ultrasound and focal chemistry, and I see who you're sitting next to, so I want to hear more about that later. But I think this notion of once we have the circuit, how should we go at it? And I don't see it as, I think it can be scaled to not be so labor intensive, but I think we should use our tools to kind of figure out, can we use tools to repair certain things or not? And then how can we test things out before we get into the invasive implant? So I think that, we had a big discussion this morning about the nature of how do we leverage our various approaches to these problems collectively, and not somebody's going to get 100% market share and elbow somebody else out. No one's ever going to get 100% market share. No drug, no therapist, no technology. There's an order effect that I think we can iterate back and forth. And I think the epilepsy monitoring unit environment provides a way that we can both ask interesting questions, but we can also test out some of these, what parts of these networks are necessary and sufficient. I see Corey Keller's here, and he certainly exploited that approach, brilliantly. And I think it's just kind of getting to where there's such an infinite space. Once you kind of get a set of regions that seem to be highly involved, that we just test the hell out of them to kind of figure out which ones are necessary, sufficient. I'm really trying very hard to get rid of the frontal lobe, not my own, but but in this model, that can we go back to Broca and really see this? I know the concept of the limbic system is an old concept, but what is it about PAPEs? Every region we've got can be done in an animal model, and you don't need a frontal cortex, but you do need a cingulate. I see, Bob.
Helen, thank you for making such a beautiful story about the anatomy of this. What about the stimulation parameters? We struggle with that in epilepsy because there's a long time to tell whether someone's better, but you're seeing improvement in the operating room.
Yeah.
So can you tell us how to individualize parameters of stimulation?
So I think that's like an important question, and this is where my very simple-mindedness kind of becomes a shield. That it's probably why I never do kind of behavior studies, because there's so many choices, and being able to do resting state. When we did 130 hertz, it was a total guess. Why do we do it? Because everybody else didn't. And it seemed like blocking was good. Turns out it's a really good thing. I didn't know how DBS really worked, because I probably never would have done the first experiment, because in fact, it's not depolarization block. In this setting, you excite axons and you drive neurons, but they can't keep up at 130 hertz for the most part. So you don't have precision, you have some net effect. And we learned that if you're too medial, you get too much gray matter, it actually doesn't work. You need to be in white matter. So I think, back to the first question about, an ablation, I don't think ablation is a good idea. I think whatever focused ultrasound doing is not, it's not damaging brain. Like, I would not want to be making a lesion in this area. I don't think that would be a good idea, even though the parameter of 130 hertz seemed like block. Now, we did early on, like once you get the switch, you lose your capacity to look at variance. So we tried to sneak up on people by doing low frequency to high frequency while we were doing the recordings with Allison. And even though you didn't have a behavioral effect, we weren't really getting a good signal with LFP. So there's something about the dynamical system that I don't think the measurement we're making is a good way to get the answer. And that because it's like, once the brain changes, it never goes back to where it is. I think every time you start chasing the parameters, you get lost. So in animals, we did a rodent experiment early on where we did frequency effects, and we're measuring, and there was a upside down U-shaped curve. That low frequency did not get an effect, which is what you see in Parkinson's. but we don't have an oscillation we're blocking. But you started to see the behavior, which is movement behavior, at about 40 hertz, and then it was best at around 100 hertz, and then as you got over 140, it seemed to be on the downside, and there was a delay effect. So you gave the stim, you got the behavior, it carried over, and it carried over the longest in the mid-range. But Shankar has tried to kind of look at these experiments where we change the frequency and we change the pulse width, and we get lost because I think once you get that first effect, you can't see it. I think that now that we have this marker, we can take the marker and kind of look like tuning a radio and looking to see when can you bend the marker? Can you put it off its kind of stable position by adjusting the parameters, but you can't use behavior. And I mean, the good news is because we could never kind of get a clear clinical signal, we stopped doing it. And because enough people got better at the high frequency, we just left it alone. And so maybe there's a way to model, like there have been several papers on this, one from Baylor and obviously the work from UCSF, again, in single cases, but where people are wired up in an EMU, you're looking at moment-to-moment mood, you're trying to try a million parameters and explore the state space, but everyone keeps looking at acute changes in mood. And I think that's where I'm cautious now, knowing that what happens with acute changes in behavior is not the same as what happens with stable well. There are two different signals, and that one, if you set up the model right, you can probably see changes in frequency or parameters. But the thing we want seems to have a slower time course. And I don't think we have a good experimental system to know what we're looking for.
Thank you again for a brilliant plenary. I'm sure there's many more questions and people would love to talk with you. So we will go to the break and then join us back here at 11 a.m. when we have our first keynote presentation. Thanks again, Helen.